Lasers are an attractive treatment option for patients as well as for ophthalmologists. Why? Because it is less invasive than surgery and it is an office procedure and it has the attraction of not going into theater to operate and so on. So lasers are quite a popular option as far as treatment for glaucoma is concerned. We have various lasers for glaucoma. These include the argon laser, the Nd:YAG laser, the diode laser, selective lasers, and of course the carbon dioxide laser. The slit lamp delivery systems are quite popular, the transpupillary methods. You also have the contact transscleral methods of delivering the laser. The pars plana and the endoscopic routes are also available for select certain types of lasers. Common laser procedures for glaucoma include iridotomy, trabeculoplasty, and cyclodestruction. The less common procedures are also listed here. You have iridoplasty, pupilloplasty, trabeculotomy, goniophotocalculation, and the deep sclerectomy using the carbon dioxide laser. I'm going to talk primarily about trabeculoplasty and cyclodestruction today. Iridotomy is commonly performed by most ophthalmologists, and there is nothing really new about iridotomy. Trabeculoplasty and cyclodestruction have seen a lot of newer lasers and methods. I'm going to talk about that today. So, a word about trabeculoplasty. Weissenwitter introduced the ALT in 1979. Thereafter, Mark Latina pioneered the SLT, and it was FDA approved in 2001. And we also now have the micropulse diode trabeculoplasty for use in clinical practice since 2008. Where do we do the laser trabeculoplasty? We can offer it as a primary therapy for patients with primary open-angle glaucoma, ocular hypertension, pseudoexfoliation, pigmented glaucoma, and of course glaucoma and pseudophakia and so on. Primarily when there is poor drug compliance, pregnancy and lactation, also whenever you feel that patient is comfortable and does not want to use drops and so on, it can be offered as a primary first-line therapy. Supplement therapy can also be done when you feel that the drug is not enough and patient is not willing for surgery and you want to defer it for some time. When you've already done a trabeculectomy and you want some additional IOP delivery, you can also consider SLT in these situations. The prerequisite for laser trabeculoplasty is a gonioscopy. And very often people would mistake angle structures and they mistake the pigmented trabecular, pigmented Schwalbe's line for the trabecular meshwork. So a good gonioscopy, understanding all the structures and being able to treat the correct structure and in the angle is very important. When the angles are closed and trabecular meshwork is not visible, when your cornea is hazy, when you have aphakia with vitreous in the antechamber, neovascular glaucoma with close closure with new vessels, active uveitis, angle recession glaucomas. These are all conditions in which the trabeculoplasty is less likely to work and is a relative contraindication. The various lasers that have been used in trabeculoplasty are the argon lasers, the selective laser, and the micropulse laser. We have different lenses to apply the laser into the angle. The rich lens, the Latina lens, and the trabeculoplasty, the Vogue Rapid SLT lens. My favorite is the Vogue Rapid SLT lens, and it has the ease and convenience of having 4 mirrors and less rotation on the eye, good visualization. Really want to see the angle well and visualize the structures well. The Rapid SLT is really a nice lens. Latina lens is also a good lens, and so is the rich lens. Depending on your preferred practice and ease of use, you can decide which lens to choose. How do you do ALT? The junction of the anterior 1/3 and the posterior 2/3 of the trabecular meshwork is treated. The energy level is set to induce a reaction of slight blanching of bubbles in the treated area. As you can see, the placement has to be just at the junction of the 1/3 and the 2/3 of the trabecular meshwork. You should not go posterior or too anterior. Anterior will result in synechia. Posterior will probably make it ineffective and so on. So the best is to have it at the junction. The different type of lasers have different mechanisms. The SLT would have a selective destruction of pigmented TM cells without thermal damage or collateral damage, is repeatable, and the endpoint is small bubble formation. Mild postoperative inflammation is possible. The spot size of each of these laser parameters are different. With the SLT, it's about 400 microns, and the ALT, it's about 50 micron spot size. You can see the spot size in the picture below. The ALT spot size is small, the SLT is large. and the MLT is about 300 microns. You will find that the large part of the SLT actually precludes good visualization. You focus on the trabecular meshwork, and then you straddle the large blurred kind of a spot on the trabecular area, and then start the laser. You will not get a very clear focus of the 400 micron spot size. The unique features of SLT is that it is selective, targets only the melanin-rich cells of the meshwork. It is non-thermal, so the pulse duration of the SLT is below the relaxation time of the thermal relaxation time of the trabecular tissue, therefore eliminates thermal damage. It can be repeated without causing much harm, and it is, as you can see in this picture from literature, the meshwork remains intact without the signs of tissue damage, whereas in the ALT, you will see a crater-like damage in the trabecular meshwork. Post-laser, you would continue the glaucoma medication for some time till a review. No steroid drops are generally given, but it is not harmful to give steroid drops or non-steroidal drops. I'll come to a publication regarding the use of steroids post-SLT. You can check the IOP after about an hour, then after a week, and maybe even after a month after the laser. The best effect of the SLT is usually seen several weeks. Maybe a month would be the ideal time to really evaluate the response to trabeculoplasty. How does the SLT compare with the older generation ALT? This is a review from Survey of Ophthalmology. The SLT was not inferior to ALT in this kind of review analysis, showing that the SLT was non-inferior to ALT and similar in terms of IOP lowering as far as treatment success is concerned. And how does it compare to medication? It is again not inferior to the medication and probably works like one drug, like a prostaglandin kind of drug. It will be lowering the intraocular pressure by about 20 to 30%. And it's comparable to one drug. It's not inferior to medication as far as IOP lowering is concerned. Some complications can be noted. Mild discomfort and photophobia can be there for a few days. An increase in IOP happens in some patients, and you must need to monitor that and treat that if there's a spike in the IOP. Generally goes off in a few days. Very rarely you can have a sustained IOP rise of less than 1%. So mind you, keep this complications and discomfort as well as the IOP rise, and do inform the patients that this is a possibility. Otherwise, people might turn around and ask you as to why the IOP is shot up when you're trying to lower the intraocular pressure. So follow-up is mandatory even after completing the laser. Check the IOPs 3 months, 6 months, follow up the glaucoma, do the visual fields, look at the optic disc. Follow-up for glaucoma is, needless to say, like any other glaucoma patient, you must follow up. How much to treat in the angle? You want to treat 90 degrees, 180, 360. The 360 is the commonest to perform procedure. I always do 360 most of the time. Very rarely we would do 180 degrees when there's intensive trabecular pigmentation like pseudoexfoliation or pigmented glaucoma. I would do 180 degrees and evaluate the response in one-eyed patients and patients with advanced glaucoma. I would evaluate the response with 180 and then go ahead and complete the rest of the 180 and so on. It would be comparable to one drug like latanoprostol, I already mentioned. A 20, 25 or even 30% IOP lowering drop can be expected in some patients. A 20-25% modest lowering will be expected in most of the patients. In a few, say, or 10-20% of the time, SLT will not work. It will be ineffective. The IOP may remain unchanged. In those patients, don't consider repeating the SLT. If it has not worked at all, a repeat SLT is unlikely to work. And it has worked well for the first 6 months. Sometimes the effect will last for about 2 years or 3 years. And I have patients in whom SLT effect still lasts for many, many years. So keep evaluating the response to treatment and consider repeat only when it has worked initially. Many publications have come out regarding the SLT as a primary treatment, and a cost-effective alternative to medication can be offered to patients with OAG and OHT and other types of glaucomas. The LIGHT trial has been the one which has been most talked of, and you can look up the LIGHT trial and its follow-up trial of 6 years now. LIGHT trial has clearly shown it is a very cost-effective alternative that can be offered as primary treatment. This has become quite popular in the UK now. What's recent in SLT? You have the nano SLT, which has a lower fluence than the regular 3 nanosecond SLT. This is a 1 nanosecond exposure SLT, which is a portable machine, fits onto the standard slit lamp. We also have many of the combo SLTs, which are combined with the YAG laser. The combination of the YAG actually makes it more cost-effective for the glaucoma clinic, in which you can have the YAG procedures being done for iridotomy and so on, the YAG. And then you have the capsulotomies, of course. The SLT will be part of the machine, which it sort of cross-subsidizes the investment for the hospital. The DSLT is a newer method of non-contact SLT, in which it's a direct SLT. It's an Israeli company which has come out with this machine. It's slowly becoming popular in certain centers in Europe and in Israel. And the Belkin DSLT is not yet available in India. It applies the laser without contact on the limbal area, and the same effect as what we see the SLT being applied through the angle is said to be achieved with the DSLT. This is the new type of SLT is available. As I already mentioned, when SLT has been done and has worked well, you can consider a good repeat SLT. But we can expect that the repeat SLT would probably give you less response than the initial as the response after the first SLT. Post SLT, you can consider giving non-steroidal drops or steroidal drops, and you will find that initially it used to be talked of as an inflammatory mechanism of SLT with underlying reduction efficacy when you give anti-inflammatory procedures. It is not true. You can actually give NSAID or steroids post SLT as an auxiliary agent. You will find that it's quite safe to do that for the patient's comfort and for as well as reduce inflammation. This was published in the SALT trial. Coming to cyclodestructive procedures, we would do cyclodestructive procedures when the raised intraocular pressure is there in a painful blind eye. There's a repeated failure of other glaucoma procedures, post-PK glaucoma, post-VR surgery and uncontrolled glaucoma, glaucoma and aphakia, congenital glaucomas, unresponsive to standard therapy. You would avoid surgery in sick patients who don't want any other procedure. Those patients also we consider the diode kind of laser procedures. The transscleral diode laser has been used for many years now, until recently when the micropulse has become introduced. The G probe of the standard transscleral diode laser, the laser tip is about 1.5 mm behind the anterior edge of the foot plate and protrudes about 0.7 millimeters. The settings are shown on the screen picture on your left, and the G probe is applied after peribulbar block and informed consent. You can have side effects after the diode laser, and pupillary membranes, the hyphema, inflammation, fibrin, hypotony, sometimes a drop in vision, pain, lens subluxation, scleral perforation, even rarely sympathetic ophthalmia has been reported after the diode CPC. The micropulse CPC is the new kid on the block, and this I would do in the theater with the peribulbar block. This is the newer Cyclogy 6 Cytodex machine, which delivers the micropulse of 80 seconds duration in each quadrant, each hemisphere, and 2000 is the power. And generally the duty cycle of 31.3% with an on of 0.5 and an off of 1.1. And the power settings are, as I mentioned, 80 seconds and 2000 milliwatts. You would actually use this in a sweeping motion below and above, and you would avoid the 3 o'clock and the 9 o'clock. Unlike the older laser, which is applied as spots, this should go as a sweeping motion. A firm application, use a viscoelastic, sweep movement from 9:30 to 2:30 and 3:30 to 8:30 clock positions. And the firm pressure is applied. The sweep duration is roughly about 15 to 20 seconds. So about 3 to 4 sweeps inferiorly and 3 to 4 sweeps superiorly. And it's quite effective in lowering the intraocular pressure in most of the patients. So this is a video clip of how the procedure is done, the micropulse diode laser. As I said, I would give a block, and I will also use the operating theater microscope for good visualization. And I generally do a marking so that I know which area and where I'm treating. Apply a gentle sweep using the viscoelastic from left to right. A sweep is about 10 to 12 or even 15 seconds per sweep. And you would do this both inferiorly as well as superiorly. The MP3 probe can also be applied in each quadrant like this, 4 quadrants instead of 2 hemispheres, 5 continuous sweeps per quadrant, each sweep for about 8 seconds, total of about 40 seconds per quadrant, 160 seconds per eye, and a power of 2000 milliwatts. So that's another way of treating the same micropulse laser. It is postulated that the micropulse actually works by increasing the existing UV scleral outflow without actually photocoagulating the target tissue. The laser shortens the longitudinal ciliary muscles, therefore opening up the Schlemm's canal and the trabecular meshwork and increasing the aqueous outflow by the conventional pathway. There is a newer probe now available from the company. The older one is the MP3 probe, and now we have the newer, slightly more sleek and thinner probe, which has now been introduced in the market. The advantages of the micropulse diode CPC have been a safe and effective alternative to the continuous diode. The continuous diode used to give us problems of hyphema and fibrin and violent reactions and pain and discomfort. The micropulse is more gentle on the end, can also be used in eyes with some vision potential and not just intractable glaucomas. It would reduce the need for topical medications with fewer complications. I have been using this for the last about 4 years, and I have been using it in patients with uncontrolled PSG where I don't want to do a trabeculectomy. Patients who are completely intolerant to medication, like this lady on the right. You can see post AGV and TRAB, we had a phaco-TRAB in a patient, not controlled pressure. Then we ended up doing AGV. That also did not lower the intraocular pressure adequately. So then we go ahead and do a 180-degree limited diode CPC in this patient using the micropulse. This is another patient with Boston K-Pro. With this, in these kind of patients also, the laser is quite useful. These are some of our publications. Our first Indian publication on the micropulse transscleral diode laser and refractive glaucomas, an initial Indian experience. And of course, there are many guidelines which have been published on the consensus regarding the method, the duration, the sweep velocity, and so many aspects of treatment of the micropulse. Long-term results, this has been published by the Singapore group. 33% IOP lowering at 18 months, mean IOP reduction of about 2.1 to 1.3. And this result has been published from the Singapore group. But there are problems with the micropulse CPC. The cost and logistics are a problem. The single-use probe, the new radiofrequency probe will last only about 30 minutes. You can only do maybe a couple of patients, 2 patients or 3 patients at the most. There's a mild fibrin reaction in some of them. There can be a vision loss of 1 or 2 lines in some patients. The pupil can remain dilated. There can be pain, redness, epithelial haze, choroidals are possible. It doesn't seem to work in all patients. In very severe refractory glaucoma, you will find that the IOP lowering is not satisfactory. In some patients, it doesn't work at all. So in some patients, we'll find locating the ciliary body and ciliary process is quite difficult in the large enlarged eyes with distorted anatomy. That's where the transillumination will actually help in some of these patients. And the long-term IOP, we don't know how long the IOP lowering will work in these patients. So the long-term effects are not really known. And we'll also try to avoid treating the diode laser, especially micropulse, in thin sclera, where people with extensive blood clots, hyphemas, and also a recent post-operative patients you would not treat with the micropulse. I thank you all for your attention, and I'm thankful to Dr. Litta for this invitation to participate in this program.